Hello, 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 YouTubers. Welcome to the second week of the YT course for advanced coding students. And how are you? All right, if you didn't know, I'm Mrs. J. I am the curriculum director for AMCI, and it is my pleasure to come to you live from North Carolina. We just weathered Dorian. We made it through, and I am ecstatic to be here and just enjoy this moment because we had a fabulous week last week. Last week we studied integumentary. We went over several of the guidelines. Several of you had clicked on the link and got the homework, and hopefully you all did an amazing job on that homework. If you have questions, just go ahead and place them in the comments section. The comments, not the chat, the comments, because if you put them in the comments section, your question will stay there as long as the playback is here, and your questions could perhaps help others. So if you will do that, that will be great. And in the meantime, I'd like to introduce my co-team, my co-pilots, and we're going to start first with Mrs. Tracy. She is our instructional team and intern director, and she is my right arm. She is CPC and AMCI approved instructor, Mrs. Tracy from sunny California. How are you?
Hello, hello, and I'm doing well, Mrs. J. Yes, it is nice and warm and sunny over here in California, and it is morning time for me. So good morning if you're coming over here. If you're on the West Coast like me, good morning, everyone. Good afternoon to everyone else. I'm so glad to be here and be joining you for our second week of our YT Advanced class. We have a great class. That we have prepared for you today. So excited to get started. Thank you for joining us, everyone.
Yes, yes. And thank you, Mrs. Tracy, for being here too. And we have another co pilot today with us, Ms. Rochelle. She's our partnership director, marketing director at AMCI, and she is CPC certified and she's an AMCI approved instructor. She's coming to us live out of Louisiana, and we call her the AMCI MVP. Ms. Rochelle, how are you?
Thank you, Mrs. J. I'm doing great. And hello, coders. It's my pleasure and an honor to be with you today. And thank you for having me, Mrs. J. I'm really looking forward to a wonderful class with all of these coders. Thank you.
You are welcome. You're welcome. All right. You know what? We have some other co pilots in the house. In fact, they're in the chat. I want to shout them out, Miss Tiffany, Miss Angela, Miss Sarah, Miss Anna, Miss Jody, Miss Mia. Thank you for being here. We appreciate you. And then others that I may not have mentioned may be showing up. So I just want to tell you that we appreciate you. And please go ahead and show them what you do in our classrooms. They answer your questions. They are good. So if you got them, coders, you can ask away right in your chat. It's on the right-hand side. All right, so we got to do our due diligence. Yeah. And you know what we have to do? We got to tell you the rules. Everybody may not have been here last week, so we're going to repeat them again. The class rules. Number one, this is a reminder. This is an advanced class. There is an expectation of preparation prior to attending this class. So if you're an AMCI student, you should have viewed the lectures and completed the homework or quizzes prior to class. If you are not an AMCI student, you should have a complete understanding of musculoskeletal system coding or guidelines. You should. The pace will be accelerated. If you find yourself having several unanswered questions, you may not be quite ready for this class. Again, it is suggested to review all of the CPT chapters prior to this class, specifically musculoskeletal system, and the guidelines. If you are currently in a comprehensive course and you've studied musculoskeletal system, this class today is for you. If you are a new coder, this course may not be for you. And if you are a novice, contact our customer service. You can go right down in the discussion, well, the comment section, right above the comment section, we have the link to our customer service department. And would you believe that we have a free introduction to medical coding course that you can take? So if you're brand new to coding, this may be too heavy. You may need to start with our introduction course. And we have playbacks. As soon as we finish today, this presentation will become a lecture or a playback or a video on YouTube, and you can watch it until we take it down. And I believe we'll take it down on December, like the end of December, so that we're current. All right. And finally, we have homework. Homework will be available in your comments section, same place, right above the comments section, and it'll be there for 24 hours. Yes, don't forget that you should already have some experience with CPT guidelines, and class will move at a faster pace than usual. All right, so let's go over the goals for today. To review guidelines for the musculoskeletal section of CPT. Number 2, to provide scenarios that will further clarify the more complex guidelines. Number 3, CPT documentation tips. Yes, we're going to teach you some chun. And 4, demonstrate the importance of forensic reading. And don't forget, coders, class will move at a faster pace than usual. And our course outline, if you need to know, number 1, last week, week 1, we studied integumentary system guidelines. Number 2 is week 2. This week, we'll discuss musculoskeletal system guidelines. Week 3, respiratory. Week 4, cardiovascular. Week 5, digestive. Week 6, urinary male female. Week 7, nervous eye ear. Week 8, radiology anesthesia. Week 9, pathology. Week 10, medicine. And unfortunately, we will not cover evaluation and management or ICD-10-CM or PCS. If you need instruction on E&M, we have an awesome, it's a lecture. It's a short lecture, but I think you will gain a lot from it. If you just search our channel, you'll see the evaluation and management with Mrs. Tracy. Or if you need more, we have an E&M course. So contact customer service for information, and you can even get CEUs by taking that course. Also, ICD-10-CM or PCS, we do not offer it, but we do have a course for these as well. All right. Don't forget, class will move at a faster pace than usual. Now, just to kind of get you acclimated, I got a poll question for you. Yeah, just want to make sure that you know where that chat is. It should be to your right. All right. Are you ready? Okay, here it is. How confident are you with musculoskeletal system guidelines? Are you very confident, somewhat confident, barely confident, or other? Just go ahead and type your response in the chat. I'll ask again. How confident are you with musculoskeletal system guidelines? Very confident, somewhat confident, or barely confident, or type something else. Type what it is. And while you're doing that, I want you to know that the instructor speaking, that will be me, is not able to see your questions. However, our AMCI instructional team who are not speaking. They're not the presenters, so they're standing by to answer your questions. And you'll be able to identify the AMCI instructors as their name should read. AMCI instructor, Mrs. J, AMCI instructor, Ms. Rochelle, or AMCI instructor, Mrs. Tracy. So that doesn't mean that you won't be um, hearing from me. Of course, when I'm not speaking, I'll be in that chat and I'll be there to answer your questions. So ask away. All right, we have some copyright to talk about. CPT is copyright of the 2019 American Medical Association. All rights are reserved. Fee schedules, relative value units, conversion factors, and/or related components are not assigned by the AMA and are not a part of CPT. And the AMA is not recommending their use. The AMA does not directly or indirectly practice medicine or dispense medical services. The AMA assumes no liability for data contained or not contained herein. CPC is a registered trademark of the American Academy of Professional Coders, or AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concept, FTR, Chun, AMCI Fab 7, Flip Tap are all trademarks of AMCI. All right, so let's go over some guidelines. We're going to go over general surgery guidelines. Yes, the musculoskeletal system is within the surgery section. So I want to go over this CPT, surgical package definition. This surgical package speaks to the fact that surgery codes within the surgery section have they have other services other than the surgery bundled into it. There are 6 things in addition to the surgery that's included in that surgical code. So your evaluation and management, subsequent to the decision for surgery, on the day before and the day of surgery. So if an E&M service took place prior to surgery, the day before or on the day of surgery, it gets bundled into that surgery code. Also, local infiltration or local blocks or anesthesia, that's bundled. Immediate postoperative care is bundled. Um, the physician's writing of orders is bundled. Evaluating the patient in post anesthesia recovery, that's bundled, and so is typical postoperative follow-up care. All of this should not be coded separate. Now, there are some circumstances where you will code the E&M service rendered on the day of the surgery, and you can do that by appending a specific modifier, but generally it is bundled in that code, and if you want to pay it, you got to append a modifier. All right, so let's continue. Follow-up care for diagnostic procedures. Anytime you have, well, CMS has developed a follow-up days. There's a, there's a there is a list of procedures that accounts for the number of follow-up days that's included for those procedures. So those days can range from 0 to 90. If it's 0, 9 times out of 10, it's probably a diagnostic procedure like a scope. Now, when you get up to 90 or anything beyond 0, you might be talking about therapeutic surgical procedures right here. So it's important that you understand the follow-up period, and the fact that you cannot code for related services, normal related services within the follow-up period. You can't code additionally. If someone has a knee replacement and they have a follow-up visit 6 weeks later, you don't code for that additionally. It's bundled, okay, into your surgical code. All right, supplied materials. Sometimes there are procedures that do not include certain supplies, specifically when you're coding in the integumentary system or procedures that are carried out in the doctor's office more so. And if you have to code for the supplies, which are typically bundled in the surgical package, you will have to append or code 99070 right here if you're able to code for the supplies. Separate procedures. This is probably the single most helpful guideline. If you're taking the CPC exam or the CCSP exam or the CCS exam, if you understand the concept of separate procedure, you will have an advantage. Separate procedures within CPT are denoted by a parentheses. In parentheses, next to the code, it'll say separate procedure. And these separate procedures are pretty much carried out by themselves. So if a separate procedure that's documented as separate is carried out by itself, you can code it. What's complicated is when it's carried out with other procedures. If it's carried out with another procedure and it's related or integral to that other procedure, you don't code it. If it's not related, you can code it. And if you do code it with another procedure, make sure that you append modifier 59. All right, so that's all I'm going to say about that. And we're going to talk about guidelines a little further. First of all, trust your guidelines. You trust them before anything. Any little tricks or techniques or whatever you have to solve scenarios, trust your guidelines. And you have 3 different types of guidelines. All right, you've got parenthetical guidelines. These are guidelines within your parentheses. We call them parenthetical guidelines. Your second type of guidelines are your code series or chapter guidelines. And often they come right before the codes, or they're underneath that blue bold in this section. See this language? All guidelines for debridement. And third, you have general coding guidelines, and they are at the beginning of each section. So we just reviewed the surgery guidelines. Those are general guidelines that apply to all surgical procedures. Now, I want to tell you that after studying these guidelines, I've determined that these guidelines have a hierarchy. They sure do. The parenthetical guideline is your highest ranking guideline. A parenthetical guideline supersedes your chapter guidelines and your general guidelines. All right? So if the parenthetical guideline tells you to not code something, when the chapter guideline tells you to code it, you're going to follow that parenthetical guideline. The second ranking on the guideline hierarchy chart is your chapter guidelines, and then third, your general guidelines. Now, if there are no guidelines, your keywords will rule. Your keywords will drive you to the answer. At AMCI, we have a technique that we use, and we teach our students to select keywords, which will help them answer the question correctly. We just don't have enough time to do it today, so I am going to tell you that if you highlight your diagnoses and highlight all procedures, those shall be your keywords, and your diagnoses and procedures will drive you to the answer, of course, in the absence of a guideline. Now, let's get down to business. We're going to talk about the musculoskeletal system. And before we get to the coding piece, let's talk a little bit about anatomy. The musculoskeletal system is composed of muscle and bones. And the average adult contains the average adult body contains over 200 bones. Some say 206, I don't know, but over 200 bones. And the bones provides the body structure. Okay? And if you know these bones, coding in the musculoskeletal system will be that much easier. And if you are a visual or a tactile learner, I recommend, and if you don't know the bones, I recommend going on to Anatomy Arcade and click on Whack a Bone and whack, whack, whack away. You will learn the bones, I promise you. There is the web address, www.anatomyarcade.com. And we did say that not only the musculoskeletal is comprised of bones, it's comprised of muscles too. There are 650 muscles. In fact, all the way up to 840 muscles. So anywhere between there. Okay, you're not going to get a definitive number, but there are a lot of muscles. And muscles are broken down into three types. You have your cardiac muscle. Of course, that is the muscle that's around your the heart. And you know what, we are just going to I'm not going to get into that. I just want to tell you generally about muscles. And one of the things that I noticed was the muscles. If you look at these muscles, they are descriptions of size and I would say it's doing something or movement. Like right here, your gluteus maximus, your gluteus minimus, your extensor, your latissimus, your triceps. And you know what I also noticed? See those little M's with the period? That's a muscle. Okay. So if you have a scenario where you have a muscle, let's say it's an injection procedure, and they say, okay, the guideline says that you have to code, you select the code based upon the number of muscles injected. If you don't know that that is a muscle in the documentation, then you won't know. And you know what? Sometimes you just won't know. You're going to have to take a guess. But if it has a little m with a period, count it as a muscle. And also certain books have muscles, a good description of the muscles. And my ICD-10-CM, the AAPC version of the ICD-10-CM, has a good muscle section, and so does the Optum 360. So I don't want to get on a tangent about types of muscle because it's not really relevant when you're coding. What is relevant is that you can recognize that it is a muscle. And again, there are 650 muscles to 840, and we just need to know if it is a muscle or not. Also, the spine. The spine is integral to very, very much related to this musculoskeletal system. And it's important that you know the anatomy of the spine. You need to know that the first 7 bones are your cervical spine or the neck. The next 12 are your thoracic region, and the next 5 are your lumbar. And then you've got your sacrum and your coccyx. So just know that. And also the anatomy of your vertebra. It's important that you know the anatomy because a lot of the procedures are performed on the vertebra. The lamina is right here. This lamina is often carried out when the physician is trying to achieve diffusion. If the patient's in pain, sometimes a laminotomy may be carried out. A hole is placed in the lamina to achieve diffusion, to relieve the patient, or a laminectomy where they remove a portion of the lamina. And this procedure can even be bilateral. All right. So it's important that you know what you are coding for and know the anatomy of the vertebra. And the interesting thing that I find about the spine, the spinal column, is these vertebrae, they are stacked on top of each other. And there is a hole in the middle of each. And that hole is called the vertebral foramen. So they are, when they sit on top of each other, the foramen houses the spinal cord and protects it. So anytime you have any kind of trauma to that spinal cord, diffusion. Oh my goodness, decompression may be essential to carry out, to relieve the patient. So let's continue. All right, so that's enough of my miniature anatomy or A&P lesson. I think I'll leave that to Ms. Carney. She's our A&P instructor. Let's talk about the table of contents of the musculoskeletal system. We've got the musculoskeletal system. The code ranges from 20100 through 29999, and they are arranged as following. You've got your general procedures, 20100 through, wow, they're all 20999. You have excisions, wound exploration, and we're going to talk about that very soon. Excisions, introduction or removal, replantations. And then you've got grafts and other procedures, followed by the head. And as you see, it's going to go all the way down. It starts from the head all the way down, and that's how it's arranged. So you've got your head procedures: incision, excision, manipulation, head prosthesis, introduction or removal, repair, revision, and or reconstruction. Other procedures: fractures and or dislocations, other procedures. Next, we're going to talk about the neck and the thorax: incision, excision, repair, revision, and reconstruction, fracture, dislocation, other procedures. Then your back and flank, you have excisions, and the spine: incision, excision, osteotomy, fracture, and or dislocations, manipulation, percutaneous vertebroplasty, and vertebral augmentation, percutaneous augmentation and anaplasty, arthrodesis. You have exploration, spinal instrumentation, and other procedures. After the spine, we move to the abdomen. We have excision and other procedures. Then we move to the shoulder. Excision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation, manipulation, arthrodesis, amputation, other procedures. Humerus, that's your upper arm and elbow. Incision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation, arthrodesis, amputation, other procedures. Forearm and wrist: incision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation, arthrodesis, amputation, other procedures. Your hand and fingers: incision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation, arthrodesis, amputation, other procedures. Pelvis and hip joint: incision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation, manipulation, arthrodesis, amputation, other procedures. Your femur and knee. We're getting down. We're going as far as we can. Incision, excision, introduction or removal, repair, revision, and or reconstruction, fracture and or dislocation. Okay, we don't have the feet, but you get the picture. And you know something else, coders? You should notice that a lot of the procedures are similar. So we tell our students to make sure that you chun very well, because if you don't chun very well in the musculoskeletal system, you can think you're coding in the right section. It could be the right procedure, just the wrong body area. So we have a technique called chun. There is a chun video on our channel, so just go ahead and search the chun video. Maybe I'll ask one of our instructors to go ahead and find that video and place the link in the chat. And what we tell you to do is to notate at the top of the page the red bold and the blue bold on the pages where the red bold and blue bold are not, so that you know where you're coding. All right, so now let's get down to business. Just want to tell you very quickly my CPT notation guideline symbols, the quick review. Anytime you see a squiggly line in my CPT manual, that means that there are bundled items. When you see the plus sign, that means code separate or in addition to. When you see this X, this is a general do not. When you see this circle with the line through it, this is a specific do not, as in do not code modifier 62. And when you see an asterisk, in fact, you'll see two asterisks. This is a do not code in a parenthetical guideline. Remember, I told you parenthetical guidelines are the highest ranking guideline, and they supersede all guidelines. All right, when you see these two eyeballs, that means that you need to go and read those guidelines because they are extensive. Oh, let's see what happened here. Sorry about that. All right, so we're going to talk about the first procedure. This is wound exploration. Wound exploration is an exploratory procedure. Now, this procedure is carried out after a penetration or penetrating wound takes place, like a gunshot wound, a stabbing, anything that penetrates the body and that could potentially harm the vital organs in that area. So they just want to make sure that you are okay. Doctors need to explore the region. And when this procedure is carried out, often the physician will have to enlarge that wound to carry out the exploration. So yes, the bullet is small in this picture, but the physician may have to open that wound all the way up to see that entire area. And this picture looks like just the iliac crest was impacted, and hopefully that's all. And no vital organs were impacted. Now, there are a few key guidelines to help you understand when to use this wound exploration. And those guidelines really, to me, are keywords. So you got to know if you're coding for a wound exploration or something else. But again, there are some guidelines. If you're in this section right here, this pink section, it describes all of the items that are bundled in the wound exploration codes. So when the doctor opens up the procedure, let's say the doctor has to carry out debridement, the doctor removes a foreign body or performs ligation or coagulation of minor subcutaneous and or muscular blood vessels of the subcutaneous tissue, fascia, and muscle, not requiring thoracotomy or laparotomy. That is bundled. Everything is bundled except when they have to carry out a thoracotomy or laparotomy. They're going through that chest or abdomen. All right, so if a repair is done to a major structure or major blood vessel requiring thoracotomy or laparotomy, you're going to have to code in that section. So if, let's say that there is the physician has to go through the abdomen to check out the stomach. You're going to have to code from the digestive system. You do not code in this section. Remember, it's subcutaneous, muscle, and fascia that we're really addressing here. And laparotomy or thoracotomy, you definitely don't code it here. All right? Now, oh, look at this separate procedure. Yes, this separate procedure 20100, this is exploration of a penetrating wound. That means you're going to code this by itself. However, if it's coded with another procedure and if it's related to that procedure, this will not be coded. Now, if it's not related, you go ahead and code it, but just make sure that you append that modifier 59. All right, so again, just to recap, you watch those bundled procedures and you do not code from this section if it's a thoracotomy or laparotomy. And one other thing, for minor integumentary repairs, it's not coded here. You code from the integumentary section. All right, now let's get started. All right, so I'll read this one. And we will begin with our answers first. A, 32100, B, 2101, 20101, C, 20101, 21035 with a 51 modifier, D, 32100, 20101 with a 51 modifier. Michael, a 28-year-old, was involved in a brawl at Charlie's neighborhood bar and sustained a stab to the chest. The patient was taken to the ED via ambulance. The ED physician was concerned about the location of the penetrating wound and felt it necessary to comprehensively explore the wound to ensure vital organs and arteries were not injured. Thoracotomy exploration was carried out. The physician was able to explore and review the chest cavity, lungs, and pleura, and was satisfied none of these organs were impacted by the penetration. Chest muscles, fascia, subcutaneous, and dermis were repaired in layer fashion. What procedure codes best describe this encounter? Okay, coders, I'm going to give you a minute and a half. Go ahead and type your answers in the chat. Okay, I think that was a minute and a half. I hope so. All right, coders, did you say the answer was A? If you did, then that may mean that you knew how to code this or you were paying attention to the instruction. All right, so let's first highlight the keywords. 28-year-old, stab, chest, penetrating wound, comprehensively explore, thoracotomy, exploration, chest cavity, lungs, pleura, chest muscles, fascia, subcutaneous, dermis, repaired in layered fashion. All right, coders. This is key right here, thoracotomy exploration. That means we learned that if a thoracotomy took place, you do not use the wound exploration codes. All right, you got a code from the section that you're exploring, and that means 20101. 20101. This is exploration of penetrating wound chest. That's wrong. So we're going to eliminate it. Also, we're going to do something else. See right here, I'm going to go back. Next to this code, it says separate procedure. Let me go ahead and highlight it. I must have missed it. Separate procedure. There you go. Anytime you see that separate procedure, that means it needs to be coded by itself or it shouldn't be related to anything else. Okay? So that means, okay, I got to figure out how to not, how to turn this thing off. Okay, there you go. So that means it should be coded separately, but if it's and only if it's related, only if it's not related should it be coded with another procedure code. So on site, for me, C is wrong and so is D because it's related. All right, so 20101 is wrong, and so is B, C, and D. And the answer is A. We're going to code 32100 thoracotomy with exploration. And if you look at these parenthetical guidelines here, it's really important that you highlight all parenthetical guidelines. Do not report 32100 in conjunction with these codes because it could really save you time. Although it wasn't relevant here, it could be relevant when you're taking your exam. All right, coders, how do you feel? How did you do? I know some of you did really well. And now it's time for me to hand it over to Mrs. Tracy.
Hey, great explanation, great scenario, Mrs. J. And we're going to move right along, and we are going to talk about introductions and injections. Okay, so code range 20500 to 20650, you'll be coding these injections, you'll be coding aspirations here, even removals are coded here as well. So aspiration of fluid and administration of medicine are performed by inserting a needle directly into a tendon and joint or a joint. Therapeutic treatment is typically used for pain management, such as anti-inflammatories and anesthetics, and this can be achieved by an injection into a tendon sheath, a ligament, a trigger point, or a ganglion cyst. So as you see on the screen here, we have some inflamed trigger points, and basically what a trigger point is just painful areas of muscle that contain trigger points or knots of muscle that develop when your muscles can't relax. Okay, so for a trigger point injection procedure, a small needle is actually inserted that either it contains a local anesthetic, and sometimes it can have a corticosteroid in there, and it helps just to alleviate that pain. So your guidelines for this, you want to know the number of muscles. We'll know if you're coding for muscles or joints, if you're coding for a tendon, what exactly you're coding for. Also, know the number of muscles and joints. Watch the type of joint and know that these are not coded according to the number of injections. Okay, it's coded according to, for example, if you're coding trigger points, you're going to count the trigger points, not the injections into those trigger points. Okay. Some of your keywords you want to watch out for here is trigger points, bursa, joint, and muscle. Okay, so just know what you're coding for. And last thing I want to say is watch out for bundled items. Okay. And here are some key terms. Morton's neuroma is a condition that affects the ball of the foot, most commonly the area between the third and the fourth toes. Your trigger point, as I just explained, a specific point or area where stimulation by touch, pain, or pressure induces a painful response. So basically, it's just a painful area in your muscles. Arthrocentesis is the aspiration of fluid from a joint using a needle puncture. And it's important to know what a bursa is. This is a small fluid-filled sac that cushions the bone, tendons, and muscles near a joint. Okay, so right here you'll see the bursa right there, your shoulder, you have them on your knee. So those are just those fluid, those are just the, I call them the shock absorbers. Okay, all right. And you'll also be coding here for Dupuytren's contracture and basically, so first of all, let's go ahead and talk about what fascia is. And I know we talked about this a little bit last week as well, but that's basically a sheet of fibrous tissue that envelops or surrounds the body beneath the skin. It also encloses the muscles and groups of muscles and separates their several layers or groups. Okay, now Dupuytren's contracture, that's a disease of the palmar fascia, resulting in the thickening and shortening of fibrous bands on the palmar surface of the hand and fingers, resulting in a characteristic flexion deformity of the fourth and fifth digit. So you can see right here in the illustration, basically it just makes it to where you're not able to extend your fingers. Okay, so for that, there's actually a collagen enzyme called collagenase, and that can be injected to treat that Dupuytren's contracture. And basically what it does is that enzyme just eats away at the collagen, causing that structure to weaken, okay? And then the doctor can go in there and kind of manipulate the fingers, break up that tightened tissue, and restores that finger's mobility, okay? And that there's a code to treat that, actually. If you look at code 20527 on page 118, that is the code to treat that Dupuytren's contracture. Okay, here's some more key terms you want to look out for. Aspiration, again, that's the removal by suction of a gas, fluid, or tissue from a body cavity or organ, from unusual accumulations or from a container. A ganglion, this is a cyst that contains mucopolysaccharide-rich fluid within fibrous tissue or occasionally muscle, bone, or a semilunar cartilage, usually attached to a tendon sheath in the hand, wrist, or foot, or connected with the underlying joints. Okay. And here you see removal of fluid. So that's just the aspiration of the fluid from the ganglion cyst there. Okay. And then, okay, so Mrs. J talked to you about, notating your manual when you're going through your chunning and stuff. Just want to watch out for some things when you're coding in this section. So again, we are coding the number of, like for instance, if you're coding trigger points, you're coding the number of trigger points, or the number of muscles, not the number of injections. Okay, so just pay attention to that. And you might just want to document at your code level what you're dealing with. Okay, so for example, in this code family 20552, you're coding there for muscles or trigger points. Okay, and at 20600, that's your small joint or bursa. Okay, which it gives you examples of that. So your small joint or bursa would include your fingers and toes. And then at 20605, that's the intermediate joints and bursa. That's your, some examples of wrist, your elbow, your ankle, and finally at 20610, those are your major. So that's your major joints and bursa. So your shoulder, hip, knee, and the subacromial bursa. Okay. Some other things to notate is your ands and ors. So in 20552 there, that family, you see this is for a single or multiple trigger points, okay? And it's coding for the muscles, it's coding for the muscles there, okay? So 1 or 2 muscles in 20552. If you're coding 3 or more, you're gonna be at the 20553 code, okay? And it also pay attention to that parenthetical guideline there. So if imaging is performed, you're going to refer to those radiology codes. But over here in 206600, make sure you're boxing those, we call these game changers, the and or. So this can be for a combination of anything here: arthrocentesis, aspiration, and or injection. So it could be all 3 of those or just one of them, because it says and or, okay? And then also pay attention to, on this one, we have a code for without ultrasound guidance and with ultrasound guidance, okay? So just know if your scenario is with ultrasound or without, okay? Make sure you're at the right code. And pay attention to your do nots down there. So you might want to notate that with those little asterisks. And then if you have your fluoro, CT, or MRI guidance, you're going to refer to those radiology codes. Okay, going over to 20605, again, there's our and or. Okay, pay attention to that. And same thing at the bottom with 20610. Okay, so those are your game changers. You want to make sure you draw your attention to those. Okay, and when you're taking your exam, looking at this, there's a lot of codes that we're dealing with. So if you're jotting down at the code level what you're dealing with and what distinguishes each one of these code families, it's going to save you a lot of time. Okay, so if you know that it's coding for say the knee, you're going to be at your major joint, so you're going to be down here. Okay, so that really is very helpful. Okay, I know when I took my exam, that was extremely helpful for me. So hopefully it is for you as well. So let's go ahead and move on. And I do have a scenario, and here's the answers. We have A, 20552, B, 20553, C, 20610, or D, 20553 times 3. A 39-year-old involved in a motor vehicle accident a year ago arrives to the pain clinic with complaints of neck pain and left-sided radiculopathy complicated by cervical degenerative disc disease. NSAIDs and physical therapy have been unsuccessful, and the patient requires multiple trigger point injections. The left multifidus, trapezius, and right levator scapular were injected. The area was cleansed and bandaged applied. Which procedure codes best describe this encounter? And I'll give you a minute and a half. Your time begins now, and good luck. All right, everybody, get your answers in. How'd you do? Okay, so let's go ahead and see what's going on here. So I like to always observe my answers. So we have, looks like B and D have the same code. However, we have a multiplier there on D. 20, the answer in A is close to the other two. And then we have C, call that the oddball because it's very, it's spread out from the other codes. So let's go ahead and see what's going on. So our answer is going to be B. All right, and I have my keywords: 39-year-olds, MVA, year ago, neck pain, left-sided radiculopathy, cervical degenerative disc disease. We have multiple trigger point injections: left multifidus, trapezius, right levator scapular. Okay, so and inject it to should have been one of my keywords, but okay, so we have injections here. 20610, I'm going to look at that first just because it is my oddball. I like to look at my oddballs first. I'm like that. So this is for arthrocentesis, aspiration, and or injection. So it could be a combination of any of those. And I do see, yeah, we are dealing with injection there. There's a keyword. However, this is coding for the major joint or bursa. And what we're coding for here is our multiple trigger point injections of the muscle. Okay, so definitely we're not coding for a major joint or bursa. So as I suspected, we can go ahead and get rid of answer C. Okay, so now we're going to look at 20552 and 53, see what the difference is. Well, those are in the same family, and those are indeed for trigger point injections, okay, single or multiple trigger points. Okay, so we have, it says multiple trigger points, so that looks good so far. I like that code language. However, this is coding for one or two muscles. Okay, and how many do we have? Well, these are all muscles. The multifidus, the trapezius, and the right levator scapular are all muscles. So that is 3 muscles, right? So 20552 isn't quite giving us what we need, okay? That's only coding for 1 or 2 muscles, and we need to code for 3. So just like that, we can go ahead and get rid of answer A, and we're down to that 20553 code. Now that's for single or multiple trigger points, 3 or more muscles. So that's covering our 3 muscles that we need, okay? So D is coding for a multiplier. We don't need a multiplier because in this case, it's not telling us to code each one separately. It is saying that it includes 3 or more muscles. So there's no need for a multiplier on this code. So we can get rid of answer D. And we're just simply going to code 20553. Okay, and that's it. So type in the chat, what'd you think of that one? Hopefully, if you didn't get it correct, hopefully you understand it now. And we're going to move right along. And I have another scenario for you. All right, here's our answers. We have A, 20650 LT modifier, S82.202A, B, 20650 LT modifier, S82.202B, C, 20690 LT modifier, S82.202B, or D, 20692 LT modifier, S82.202B. A male U.S. professional tennis player at a Roland Garros French Open practice court suffered a fracture of the left tibial shaft after tripping over a
Okay, not sure where you went, Mrs. Tracy. I'm going to give you a second or two to come back. And in the meantime, hello?
Hello, can you hear me, Mrs. J?
Yeah, I think you,
Hello?
yeah, I can hear you now, but we
Oh,
lost you. So
oh, you
maybe,
did?
yeah. So maybe you could do Roland Garros, France, start from up there.
Okay,
Sorry
did
about
you hear
that.
the last scenario, Mrs. J?
Yes, you
Oh, you
just
did.
stopped.
Okay,
Mm-hmm.
I think I'm experiencing some audio issues. I'm so sorry. Okay, let me start over. Thank you for telling me, Mrs. J.
Oh, you're welcome.
Okay. Okay, so we have our answers. Let me go ahead and start Oh, maybe I already read the answer, so I'll start with the scenario. A male U.S. professional tennis player at a Roland Garros France French Open practice court suffered a fracture of the left tibial shaft after tripping over a tennis ball. The ED physician was reluctant to repair the injury and preferred an orthopedic specialist perform the repair. However, as a temporary measure, stabilization of the injury was the physician's preferred acute treatment. A small incision was made over the left proximal tibia. A traction pin was inserted through the bone, and weights were attached to stabilize the fracture temporarily until fracture repair can be performed in the U.S. Which procedure and ICD-10 CM code or codes best describe this encounter? And I will give you a minute and a half. Good luck. Your time begins now. Okay. Alrighty, so hopefully everybody can hear me, and let's go ahead and look at what's going on here. So we have, if I look at my answers, A and B are the same first listed code, but I do notice they're all pretty close together, so we're gonna just have to use our forensic eyes here. And then look, we have some ICD-10 CM codes, so we're gonna have to get to that book. Okay, so let's go ahead and reveal the answer. Our answer is going to be A. Let's find out why. Okay, so if we look at, our keywords, sorry, I almost forgot that. We have fracture, left tibial shaft, temporary stabilization, incision, left proximal tibia, traction pin, insert it, bone, stabilize, and fracture temporarily, okay? All right, so we have, if we look at 20690 first, this is for application of a uniplane pin or wire in one plane, unilateral. So basically, this is for an external fixation system. It doesn't mention anything about this doctor stabilizing this fracture with a fixation system. It's just saying that he's placing a traction pin, okay, in the bone. So definitely we're not going to be coding 20690 because that is for an external fixation system, which you'll be learning about shortly. So we're going to go ahead and get rid of answer C. And we can also get rid of answer D because that is also coding for a external fixation system. Okay, so get rid of answer D as well. So now we're just down to that code 20650 for our CPT code, and that is for the insertion of a wire or pin with application of skeletal traction. So this was a traction pin, and that's what we're going to be coding this as here. Okay, so 20650 is going to be our first code there for our CPT, and then we're going to go to our ICD-10. So I always say when our CPT codes match, we got to go to that ICD-10 book for the tiebreaker, okay, to find out what answer it's going to come down to here. All right. So if we look at S82.202, the difference between those two codes is the 7th character, okay, that 7th character extender there, which is either going to be an A or is it going to be a B. So let's go ahead and look. So S82.202 is for unspecified fracture of shaft of left tibia, okay? And the 7th character extender, we got to go up to that 7th character extender box and look at B, which is for an initial encounter for an open fracture, type 1 or type 2. So does it tell us in our scenario whether we're dealing with an open or a closed fracture? I don't see that it says in our scenario whether we're dealing with open or closed. So what does our guideline tell us to do? If you look up under your notes section, it says that a fracture that is not indicated as opened or closed should be coded to closed. So your default would be closed. So we can't code this as an open fracture unless the doctor specifically documents that it was an open fracture type 1 or type 2, and that didn't happen here. So if it doesn't happen, we can't code it. Or, if the doctor didn't say it didn't happen, so we can't code it. All right, so just again, remember, if the type of fracture is not documented, it is coded as closed. Okay, so therefore we can get rid of answer B, and that 7th character extender was going to be A for initial encounter for closed fracture. Okay, and that's it. Final answer. So how'd you do? That makes sense to everybody? Talk to us in the chat. And I think with that being said, I'm going to pass it on over to Miss Rochelle.
Yes, indeed. Thank you, Miss Tracy. That was a wonderful scenario. And actually, what a great introduction to our next topic over here, because we are indeed going to talk about fractures. So thank you. And coders, how are you? Are you ready? All right, good. So let's go ahead and move along. And at this point, if you're just joining us, we are going to be talking about fractures and fracture treatments. Okay, so to start, a fracture is basically a break or a crack in the bone, and a bone can or a broken bone can range from a thin crack to can sometimes be a complete break. Now we have to remember that since it is a fracture is a crack on the bone, and that also means that anywhere in the body that has bones can fracture. So it's really a good thing to always pay attention to the location of the fracture when we are coding. And of course, we do have some guidelines when we talk about fractures. So let's go over them um, right now. So the most important thing for us to know is that when we're coding for fractures, it's actually based upon the treatment. So we can see it here in the guidelines on page. If you're on CPT page 116, you will see it here. The type of fracture, meaning to say a fracture can be an open, compound, or closed. It doesn't matter what type of fracture that would be, because the type of fracture does not have any correlation with the type of treatment. So what that means is that a closed fracture may be treated as an open treatment fracture or other way around. So basically what we need to pay attention to is the type of treatment of the fracture. Okay? So with that being said, we're going to go ahead and review the definitions of these treatments for fractures. So let's go ahead and start with the closed treatment as defined in the guidelines here. So a closed treatment for a fracture specifically means that the fracture site is not surgically open. So that should be your keyword there, meaning to say that exposed to the external environment and directly visualized. So meaning to say if they didn't open up your skin, that means that it's closed treatment. Okay, so this terminology is used to describe procedures that treat fractures by three methods. It can be without manipulation, it can be with manipulation, or with or without traction. So a good way, actually, so I'm going to bring you over here to my right side where you can see the code um, series here for fractures and dislocations in this chapter. What we teach our student is to chant this code series very well, because a really good idea to have a quick glance on those type of treatments. It really helps the students to narrow it down for, when they're looking for the exact treatment they're coding for based upon their scenario. So what we're going to do is show you a little bit of an illustration of how we're going to chant it. So if you can see here, we are going to box the treatments. So 21310 is a closed treatment of nasal bone fracture. We're going to box it, and we actually sometimes actually do go over and color code it. So for like, if you chose red for closed treatment, you can do that. 21315 is also a closed treatment. We're going to box closed, and 21337 is a closed, another closed treatment. This one is for nasal septal fracture. So that's gonna give you a little bit of visual heads up, like, hey, okay, these codes are closed treatments. Okay, so we're going to go back over here to our guidelines, and then we're going to talk about the open treatment, and then we're going to chun. Okay, so for an open treatment, it is defined as used when the fractured bone is either surgically opened, so that surgically open there is going to be your keyword, or exposed to the external environment, and the fracture, or where the bone ends, visualized, and internal fixation may be used. Number two, the fractured bone is opened remote from the fracture site in order to insert an intramedullary nail across the fracture site. So the fracture site is not opened and visualize. So those are the definitions of an open treatment. So what we're going to do here is we're going to notate the code series again, and we're going to color code it as green. So as you can see, just very quickly there, if you look at that code series now, you can definitely distinguish a closed treatment code from an open treatment code. And that should really help you, especially when you are doing your CPC exam. Now, the final one is going to be the percutaneous skeletal fixation. This is defined as a fracture treatment, which is neither open or closed. And in this procedure, the fracture fragments are not visualized, but the fixation pins is placed across the fracture site, usually under X-ray imaging. And sometimes we put it as blue there, as you can see. So 21340, that is your code for percutaneous treatment of naso-ethmoid complex fracture with splint, wire, or head cap fixation, including repair of canthal ligaments and or nasolacrimal apparatus. So as you can see, that is your percutaneous treatment. So that's a good way to help out our students to identify again the type of treatments. And just always remember again that treatment is what the doctor does to correct the fracture. So really, really good idea to be forensic on what type of treatment you are coding for. Okay, so hopefully everybody is clear on that one. And then we're going to go ahead and move along with the instrumentation for halo, pins, and implants. Okay, so instrumentation such as an external fixation device, you can see it here. We call it external when it's outside of the body. Involves the use of hardware. Examples are the pins, wires, rods, rings with an attaching device or mechanism for temporarily or definitive treatment of bony deformities for fractures. So let's go over a quickly on the guidelines for this. I think we went over the percutaneous skeletal fixation already, but I just wanted to show you. It's very good to have a good illustration of what a uniplane external fixation system is. As you can see here, you can see a one plane there, and this is external, meaning to say that it's outside of the body. When they're saying it's internal, it would be inside, where the bone is. So that would be considered as an internal fixation. A multiplane, as you can see over here on your right, that's when you see multiple planes outside of the body for a multiple external fixation system, and that will be coded as 20692. And again, just to remind you, the type of fracture again does not have any coding correlation with the type of treatment. Oops, I should have the box here. But that's really the one thing that we need to pay attention when you're coding for these fractures. And we have one more thing that we need to discuss. Another good idea or a good coding tip that I would like to share when you're coding for fraction is that, or fractures, is that manipulation. So sometimes you will see manipulation documented. It can also be documented as reduction. So what this means is that basically a manipulation is when the doctor or the surgeon will basically um, restore the fracture by means of like manually applied force, like as you can see over here. So sometimes, like I said, they would call it manipulation and sometimes they would call it as reduction. So just pay attention to that code or those documentation. Now, another final thing. So if we're going to put everything together, so remember that our FDRs for fracture treatments are the things that you have to pay attention to is that you need to identify the type of fracture treatments. Remember the type of treatment. I'm going to say it again. The type of treatment is not related to the type of fracture. So what you need to watch out for is the type of treatment that you're coding for your encounter. Okay. Now, if the type of fracture is not documented, as Ms. Tracy mentioned earlier, the default is going to be a closed fracture. Another thing is the cast. So we're going to talk more about cast later on, but as far as the fractures goes, initial cast application and removals are bundled into the initial treatment. And that's it. So what do you say, coders? Are we ready to code? I have a scenario here for you. And I'm going to go ahead and get started. To give you the answer choices, we have A, 24574 with modifiers 54, and RT, 24615 with modifiers 54, modifier 51, and modifier RT. For your answer choice B, you have 24576 with modifier 54 and RT, 24620 with modifiers 54, 51, and RT. For C, you have 24577 with modifiers 54 and RT, 24600 with modifiers 54, modifier 51, and modifier RT. And for your answer choice D, you have 24565 with modifier 54 RT and 24605 with modifier 54, modifier 51 RT. So here's your scenario. A 22-year-old female sustained a dislocation of the right elbow with a medial epicondyle fracture while on vacation. The patient was placed under general anesthesia and the elbow was reduced and was stable. The medial elbow was held in the appropriate position and was reduced into an acceptable position and elevated to treat non-surgically. A long arm splint was applied. The patient is referred to an orthopedist when she returns to her home state in a few days. What is or are the correct CPT code or codes are to be reported, and I'll give you a minute and a half to solve this. I'll put in the time, and coders, you may begin. And when you're done, put your answers in the chat. All right, coders, that is time. How do we do? All right, get your answers in the chat. And then let's go over this. Let's break this all down. I do have to say that if you answered D, then you would be correct. Great coding. So we always go with our keywords when we solve scenarios in over here at AMCI. So let's do that right now. So we have a 22-year-old female, dislocation, right elbow, medial epicondyle fracture, general anesthesia reduced. We have another medial elbow reduced non-surgically. So with that, with those keywords, I can identify that I'm dealing with two types of fractures here. We have the medial epicondyle fracture and the medial elbow. Okay, so looking at my code range here, let me go ahead because I don't really have anything much to start or a heads up here. So I'm just gonna go by each of them to identify if my, the correct type of treatment is correct. So 24575. Let's go over there. This is coding for an open treatment. Now look at our fractures there. Remember, when we say or when the type of fracture is not indicated, the default is yes. So if you said the default is going to be closed, then you would be correct. So that means that 24575, this is coding for an open treatment. When you see that right off the bat, you know that that's going to be wrong. So we're going to go ahead and eliminate the answer. Isn't that quick? Okay, so the next thing, if you look at 24576 there, that's an for closed treatment like this, but always also pay attention to the body location. This is the closed treatment of a humeral condylar fractures. Now looking back in our keywords, we were dealing with a medial epicondyle fracture and a medial elbow. So it's not a condylar. So we're going to go ahead and eliminate that as well because that is the wrong body location. And look, answer C, 24577, comes from this family. And that's actually coding for with manipulation. However, it doesn't matter. In this case, this is not going to be where we're going to code from because, again, this is a wrong body location. So we eliminated C as well. So that's great. So now we're left with your answer D. So we're going to go ahead and take a look if this is in fact correct. 24565. So that is another family there. The parent code says close treatment of humeral epicondylar fracture. So we like that. Medial or lateral, we were dealing with medial. And since it's saying medial or lateral, so that is, we can code it from here. And we know that there was manipulation because it was reduced. So remember that, reduced or manipulation. So we like that so far. So we can take that as our code for that first fracture there. And then we also have the medial elbow. So it was treated with non-surgically. So we can go ahead and look at 24605. Comes from a family here. So we're going to start to take the parent code treatment of closed elbow dislocation and 24605 because this did require general anesthesia. So that's going to be our code. So we like that. Now the modifiers here, as far as the modifiers goes, that is bearing the 54 modifier because remember, if you look, actually this surgeon who treats or the doctor that treated this patient right now is actually not going to be the same surgeon who is going to treat the post-operative care. So meaning to say, in this encounter, this surgeon is only coding for the surgical care only. Okay, because this patient is on vacation. So when she goes home, she's going to be seeing an orthopedist. Okay, and I think that's it so far. So that summarized everything. So our code is going to be 24565 with modifier 54, as I've explained, RT 24605 with modifier 54 and modifier 51 for multiple procedures and RT. And your answer is D. All right. So how do you feel about these scenario coders? Tell us in the chat just to remind you that we are not able to talk to you while we are, discussing, but I am actually going to go ahead while I turn you over to Mrs. J. I'm going to hang out over there in the chat in case you might have questions for me. So, Mrs. J, it looks like it's going to be back to you at this point.
Okay, if you can hand it over to me.
All right, coming right up. Thank you, Mrs. J.
Thank you. What an amazing presentation. Didn't she do great? Chat, go ahead and let her know. You know what? Ms. Rochelle, you are going to be my fracture instructor. Yes, you are. Okay, now it's time to move on. You've learned how to do fractures. You've learned about wound treatment. You've learned about injections. Now it's time for the good stuff, spine procedures. All right, don't get too excited. All right, these spine procedures aren't as difficult as people think. Although there are many guidelines to consider, there are pretty much four guidelines that we'll need to follow, and we're going to review them. And let's get started. All right. All right. You will need to know the anatomy of the spine. The cervical spine has 7 bones. The thoracic spine has 12 bones, and your lumbar have 5. Your sacral have 2 big old fused, well, 5 bones fused, and you've got your coccyx bone or your coccy bone. All right. And also don't forget about your vertebra or your vertebrae. And just know the anatomy of a single vertebrae. And in the middle, this pink section, this is your foramen. Now, let's talk about the guidelines. I told you there were 4 common. However, the guidelines that we're going to review are guidelines the um, hmm, right before the code series. So in the spine section, right at the beginning, there are some guidelines. And these guidelines, and this begins on page 130, they pertain to your definitive procedures. Okay, and there are quite a few guidelines here, so you might want to take a look at it. Then you've got an arthrodesis that could be carried out. You can find that on page 134. Also, grafts or implants, that could be a procedure, and that's on page 122, and your spinal instrumentation on page 137. All right, so there are 4 main procedures that could take place. So it's good to read them all. All right, so number 1, your definitive procedure. This is the definitive treatment. This is the procedure that's treating the condition. Number 2, your arthrodesis procedure. This is how they immobilize the joint or the spine. Now, arthrodesis could be a definitive procedure in itself, but it could just be a procedure in addition to a definitive procedure. Next, graft. No, we'll do instrumentation. Sorry, it's arranged this way, but instrumentation, this is what they use after they've immobilized the spine. They use instrumentation to kind of keep it there. And grafting. Sometimes when they do a procedure like a discectomy, they remove the disc, grafting is needed to fill in that space where the missing disc is. All right, so you got 4 potential procedures. And there are some other things that you need to pay attention to. And here is a coding tip. Your modifier 62, make sure that if you use this modifier, these are for 2 surgeons working together as primary surgeons. So you would use the same code for both surgeons. And also, if the surgeon is not working as a co-surgeon, you would append modifier 80 or 82 for their services. So as you've just seen, there could be 4 potential surgeries, carried out, 4 potential procedures carried out in one encounter. So let's say one surgeon just is going to um, obtain the graft. But certainly that is not the bulk of the procedure. So for their portion of the procedure, they would append 80 or 82 modifier. Another tip that I want to give you, always pay attention to your parenthetical guidelines. Your parenthetical guidelines will help you when you're coding this section. All right. All right. So with that said, I have a case example for you, and this is provided by the CPT Principles of CPT. Okay. Answer A, 63077 22556 with a 51 modifier, 22845 20938. B, 63077 22556 22585 22845 and 20930. C, 63077 22556 with a 51 modifier, 22585 22845 20938. And D, 63077 22610 22556 22845 with a 51 modifier, and 20983 with a 51 modifier. The surgeon performs the spine procedure for an anterior thoracic 2-level arthrodesis, anterior single-level discectomy, anterior plate instrumentation, and structural autograft iliac crest bone graft. What codes should be reported? Okay, coders, I'm going to give you a minute and a half. Okay, coders, I gave you a little extra time because it could be take a little more time. However, if you know the guideline, it really wouldn't. All right, so I didn't actually tell you all of the guidelines, but I will review them with this scenario. The answer is A. How many of you said that? Okay, well, if you got it correct, outstanding. All right, so the way we solve this is you, when you're coding these scenarios, you have to answer some questions. First, you got to know the approach. How was this procedure approached? Well, if you look at the documentation, you have an anterior thoracic anterior single level discectomy, anterior plate instrumentation. This approach, anterior everywhere. Okay, now the only other thing that you have to do is answer what type of if the procedures are being carried out. I told you that there are definitive procedures. So you need to know, was a definitive procedure carried out? And the answer should be, go ahead, type it in the chat. Yes, a discectomy was carried out. A removal of a disc was carried out. Next, was arthrodesis carried out? If you look at the documentation, it said anterior thoracic 2-level arthrodesis was carried out. So the answer is yes. And not finally. And was instrumentation used? Absolutely. Anterior plate instrumentation. Now, finally, was there bone graft? You better believe it, an autograft, meaning it came from the patient's iliac crest. So the answer is yes. So that means we're going to have to code for all of these procedures. So that's 1, 2, 3, 4, a minimum of 4 codes. A minimum of 4 codes will be used. All right, so just to remind you, 1 disc was removed, but 2 segments were used for the instrumentation. Okay, 1 disc removed and 2 segments were used to secure the instrumentation. All right, so we had a definitive procedure, which is your discectomy, followed by your arthrodesis, followed by your instrumentation, then your bone graft. Now for a visual, let me show you. This is exactly what happened. See that empty space in there? That's where your disc was. As you can see at the top and at the bottom, these are discs, and these discs are between your vertebrae. So 1-level discectomy and 2-level instrumentation. They needed both the 2 bones to secure the arthrodesis. Now, I digressed, but I'm back. Now let's get started and let's answer these questions. Well, let's solve it. All right, so D has a code 22610. 22610 is the code for arthrodesis, posterior or posterolateral technique. Coders, didn't we say that this is an anterior thoracic 2-level arthrodesis? So therefore, 22610 is incorrect. All right. Now, if we go to the parent, 22554, this is arthrodesis. And if you go down to the actual code, 22556, this is thoracic. So let's read the whole procedure. Arthrodesis, anterior, interbody technique, including minimal discectomy to prepare interspace other than for decompression. And this is cervical below C2, but ours is thoracic. Okay, so this is correct. This is what happened. So if you look at this code, look what happened in here. They carried out a discectomy. It's included in this arthrodesis. So let's see how this plays out. Now we have a code 22585, and it's coming up that it's wrong. And here is why. This is an add-on code for each additional interspace. Coders, how many interspace are we coding for? Yes, we are coding for 1 single level interspace, single disc or discectomy. So we would not be needing an additional interspace. Only 1 disc was removed. So right away, C and B are wrong. Now, let's continue. Let's do our due diligence so we can, just make sure that you understand the complete way that this should be coded. All right, so we've got 22845. This is your anterior instrumentation for 2 to 3 vertebral segments. This is absolutely correct. We have an anterior plate instrumentation. We did use 2 segments. And if you look at the parenthetical guidelines, it tells you that you can use 22845 with the codes, with the following codes. And these are our codes indeed. Also, 20936, this is autograph for spine surgery. Okay? And 20938 is your structural, your structural graft. And of course, this is what we're looking at. This is in our documentation, the patient had a structural graft, and the correct answer, A, 63077 622556 with a 51 modifier, 22845 20938. Okay, coders, how did you do? Well, I'm not going to jump in the chat just yet. Let's try another scenario. And I'm going to ask Miss Rochelle to read it. And while she's jumping on board, I just want to tell you, if you got this correct, outstanding.
Yes, indeed. And I'm ready, Mrs. J. Okay, coders, so let's go over our answer choices first. We have A, 63075 22551 with modifier 51, 22845, and 20931. For B, we have 22551, 22840, 20930. For C, we have 22551, 22845, 20931. And for D, you have 63075, 22551 with modifier 51, and 22840 and 20930. A 37-year-old male with a history of pain, neck, and radiculopathy with failed physical therapy. CT, MRI, and myelogram all confirmed C6 to C7 spondylosis and right disc protrusion. The patient will have to have his disc removed. The patient is prepped and draped in sterile fashion, and after administration of anesthesia, a transverse incision is made anteriorly. The muscles are excised for access to the target discs. The disc between C6 to 7 is identified and removed. The posterior longitudinal ligament was removed to provide access to excise the osteophytes, and decompression is achieved. The disc space was prepared utilizing a burr drill, homogeneous structural bone grafting was inserted, and segmented instrumentation with end plates were applied anteriorly to achieve arthrodesis. All right, coders, I'll give you a minute and a half. And when you have your codes, put your answers in the chat and you may begin. All right, coders, that is time. Get your answers in, and Mrs. J is going to go over this scenario with you.
I am. Thank you so much, Ms. Rochelle. All right, I'm going to give you a few more seconds, and then we can begin. So hurry up and get your answer in the chat. All right. Okay, so the answer is, well, you know what? Here it is. The answer is C. C, did you say that? If you did, great job. If you didn't, you're going to learn something, and that is priceless. All right, we're going to start with our keywords. 37-year-old, C6 through C7 spondylosis, right disc protrusion, disc removed, transverse incision, anteriorly, muscles excised. 6C through 7, removed, posterolateral longitudinal ligament, removed, excised, osteophytes, decompression, the disc space, burr drill, homogeneous structural bone grafting, inserted, segmented instrumentation with implates, anteriorly, arthrodesis. A lot of stuff is going on. And based upon the guideline review of the previous scenario, you will see that there are indeed 4 procedures here. But I did say something was key. I said that you need a definitive procedure. Is if arthrodesis was carried out, you'll need to code it. If instrumentation was carried out, you need to code it. If grafting was carried out, you'll need to code it. But I also said that arthrodesis could also act and serve as the definitive treatment. And I believe that's what happened here. All right. We know that the disc was removed. So if we're looking at 63075, this is the code for discectomy, but it's not correct because this is a discectomy anterior, but that parenthetical guideline redirects you. It says do not report 63075 in conjunction with 22554, which is not our case. However, if you go down to the next sentence, it says to report anterior cervical discectomy and interbody fusion, which happened at the same level during the same session, use 22551. So you see how that parenthetical guideline can make you just switch your course. So it's really, really important that you read them always, especially when you're coding spine procedures. All right, so that means we don't code 63075 for anterior discectomy with your interbody fusion. So we're going to eliminate A and D. All right, the next thing we're going to do is look at code 2284540. Excuse me. This is the code for posterior non-segmental instrumentation. This is wrong because we have anterior segmented instrumentation. So B is wrong. And the answer is C, but let's keep going. Let's prove why C is the best of the 4. All right. 22551, this is the code for arthrodesis, anterior interbody, including disc space preparation, discectomy. See, the discectomy is already bundled in that code. Osteophytectomy, which we had, removal of osteophytes, and decompression of the spinal cord and or nerve roots. Cervical below C2. So we know this is our code. Now it's time to look at our instrumentation. 22845, this is the code for anterior instrumentation. 2 to 3 vertebral segments and list them separate. Also, our parenthetical guideline validates that we can use this code, and this second code, 22845, is correct. Now, our final code, 20938, this is our structural allograft. All right? And that is in our documentation. So the answer is C, 22551, 22845, 20931. Okay, coders, how did you do? All right, if you have questions, go ahead and type in the chat, and I will pick up and I'll answer your questions. So go right ahead. If you got questions for me, I'm here for you. All right. Now, I think I'm going to hand this over to Mrs. Tracy.
That is right. Thank you, Mrs. J, for a wonderful discussion. Great scenarios. And we are moving right along, and we are going to talk about foot procedures. So within the musculoskeletal section, you will code foot procedures to treat certain foot deformities. And there's two major things we need to draw our attention to here. This can cause a lot of confusion just because the medical terms, we have hallux valgus and hallux rigidus that we'll be coding from here. Know the difference between the two of them. Hallux valgus is basically a bunionectomy surgeries are coded here. So when you see hallux valgus, that is referring to a bunionectomy, okay? And bunions are caused by swelling and inflammation of that first digit, your big toe right there, and it's basically where the toe's kind of turning inward, okay? It's at an angle right there, and it can overlap or even underlap some of your other toes, okay? And then hallux rigidus, that is actually arthritis in the big toe, resulting in bone spurs or osteophytes, okay? So let's turn the page here. We're going to talk about some guidelines. But if you look on starting on page 173, this spans several pages, you'll see some of these procedures for hallux rigidus. Okay, again, the hallux rigidus, that is just the arthritis, and then the hallux valgus, that is the bunion, okay? So, and if you turn to those pages, I think there's a few pages actually that show you these treatments for these foot deformities. And our guidelines here, you want to know the type. Also watch eponyms. You'll be dealing with some eponyms here. You can identify those by those capital letters. Sometimes you'll see in the documentation, rather than it saying hallux valgus, hallux rigidus, bunion, or arthritis, you might just see it referred to by the eponym. Okay, for instance, there's a code 28300 that's dealing with Dwyer or chamber type of osteotomy procedures, and those are eponyms. So you might see that listed in your documentation rather than just osteotomy. So just watch out for that. Also watch for items that are bundled into the bunionectomy. So the things that are bundled into the bunionectomy surgeries are going to be capsulotomy, synovectomies, synovial biopsies, arthrotomies, neuroplasties, tenotomy, tendon release, tenolysis, excision of osteophyte, excision of medial eminence, articular shaving, removal of bursal tissue, placement of internal fixation, and scar revision. So there's quite a few things that are actually bundled into those bunionectomies. Bunionectomy surgeries. And keywords again to look out for: hallux valgus, again, that is bunion; hallux rigidus, that is arthritis. Also, of course, bunion, arthritis, and correction, okay? And look for osteotomy as well. Okay, and also those eponyms. Don't forget to look for those eponyms. Okay, so we have a scenario. I have answer A, 28292, B, 28289, C, 28291, or D, 28295. A 53-year-old female recreational tennis player with a history of left Hallux rigidus, arthritis of the big toe joint of the proximal phalanx base and distal metatarsal with osteophytes, arrives to the OR for repair. The patient is prepped and draped in sterile fashion. After induction of anesthesia, the surgeon makes an incision over the metatarsophalangeal joint and dissects down through the muscles. An incision is made through the capsule, releasing it, and the metatarsophalangeal joint is accessed. The joint is explored for loose bodies and other abnormalities. The excess synovial tissue presented is debrided and osteophytes are removed. A saw is used to cut the bony spurs on the metatarsal head and proximal phalanx. Artificial toe cartilage implant was inserted between the proximal phalanx base and the distal metatarsal bones to restore mobility. Hemostasis is achieved with electrocautery and the wound is closed in layer fashion. What procedure code best describes this encounter? And I will give you a minute and a half. Your time begins now. Good luck. Okay, that is time. Get your answers in, please. And let's go ahead and see what's going on here. So if I look at my answers, it looks like those codes are all pretty close together. So let's just do some forensic reading here. And I know this scenario, it looks quite long, but really it's not. I'm going to show you how we're going to get to the answer pretty quickly here. So let's go to the keywords. 53-year-old left hallux rigidus. Okay, we're coding here for arthritis. Proximal phalanx base, distal metatarsal, osteophytes, repair, incision, metatarsophalangeal joint, dissects, incision, capsule releasing it, joint is explored, synovial tissue debrided, osteophytes removed, cut the bony spurs, metatarsal head and proximal joint, implant is inserted between the proximal phalanx base and distal metatarsal toes to restore mobility. So I probably have too many keywords there, but our answer is going to be C, okay? And let's find out why. Okay, so first of all, we're going to look at this 28292, which is in answer A there, and that is for correction of hallux valgus. So if you just have that documented somehow or notated in your manual that this is for bunion, okay, this is a bunionectomy surgery. We know in our scenario, look it doesn't match our keyword. Hallux rigidus and hallux valgus, not the same thing. So we're coding here for arthritis, not bunion. So we can go ahead and know that that is going to be wrong. Okay, so trust our guidelines here. Or not our guidelines, our keywords. So we're going to go ahead and look at 28295, which is an answer D. That's within the same family. So anything within this family that's coding for a bunionectomy is obviously going to be wrong because that's not what we're coding for here. So we can get rid of A and D just like that. So pretty simple, right? So now we're going to go up to 28289, and that is for our Helix rigidus correction. Okay, so that is for the arthritis there. And you might just want to write next to that, just so you know that that is for arthritis. You might just want to write that next to that code, okay? And 28289, yes, that is for the Helix rigidus that we're looking for here. However, this is coding for saying without implants, okay? So if you notice, the two codes that are left are within the same family, and the difference between those two codes is one is coding for an implant and one is not. And if we just look at our documentation and see what it's telling us, it says that an implant was inserted, so we're definitely going to be coding this implant. So 28291 is going to be our code. Okay, so we can get rid of B, and C is the correct answer. All right, talk to us in the chat. Let us know. Did you learn something between the two of those? The Helix rigidus and Helix valgus, I hope you did. And we're going to go ahead and move on, and I'm going to talk to you about our next subject, which is going to be castings. Okay, so casts are used to immobilize a body part when the patient suffers a fracture, or sometimes a cast will be used after a surgical procedure, again for the same purpose, to immobilize an extremity. The application and the removal of the first cast or strapping is bundled into the global period, meaning that we do not code it separately. Okay, so let's go ahead and look at our guidelines. Okay, for the application of cast and strapping, okay, this is the really important guideline you need to make sure that you notate in your manual on page 178. An individual who applies the initial cast, strap, or splint and also assumes all of the subsequent fracture, dislocation, or injury care cannot use the application of cast and strapping codes as an initial service, since the first cast, splint, or strap application is included in the treatment of fracture and or dislocation codes. Okay, so notice your little bundle notation there. That is bundled. Okay. Okay, all initial casts, straps, and splints are bundled into the fracture care code. Okay, and we have some things we can code in addition. Okay, so restorative treatments or procedures that are rendered by another individual following the application of the initial cast, splint, or strap may be reported with a treatment of fracture and or dislocation code. Okay, so it's performed by another individual, they can code the treatment of the fracture and or dislocation code. Okay, and another thing that we can code in addition is I'll just read this whole thing to you. So if a cast application or strapping is provided as an initial service, example, casting of a sprained ankle or knee in which no other procedure or treatment, such as surgical repair, reduction of a fracture, or jointless dislocation is performed or is expected to be performed by an individual rendering the initial care only, use the cast, strapping, and or supply code 99070 in addition to an E&M code as appropriate. Okay, so this is basically just saying when there is no procedure that's going to be done, no procedure or treatment, and just the cast application is being done, the provider, the physician can report an E&M code, and then in addition to that, they would code that supply code 99070. And it's just important to know that when you're using that 99060, you just have to list the supplies that were used. Okay, and so just to recap, code cast separately for the following. If a replacement cast or strapping procedure is performed during or after the period of normal follow-up care, okay, so something outside of the initial placement of that. An initial service performed without restorative treatment or procedures to stabilize or protect a fracture, injury, or dislocation, and or to provide comfort to a patient. Okay, so if there is no procedure that's performed, and again, just the cast is placed, you can report that 99070, just like it says right here in the little plus on your guideline. Okay, an initial cast or strapping when no other treatment or procedures performed or is expected to be performed by the same physician or qualified healthcare professional, an initial cast or strapping service when another physician or qualified healthcare professional provides a restorative treatment or procedure. Okay, so just as it says there in your guideline. All righty, so I think we are ready to move right along. Miss Rochelle, what do you say?
Yes, we are. We're moving along, and I think we covered pretty much a lot of great chapters today, Miss Tracy. But I think it's time for us to talk about arthroscopy. So I'm going to go ahead and take the screen from you. And coders, how are you doing? If you're feeling a little stiff, go ahead and shake it off. And then we're going to talk about scopes. All right, so let's go ahead and talk about, first of all, arthroscopy. This is basically, sometimes they call this as a keyhole surgery. So it is a minimally invasive surgical procedure on a joint in which an examination and even sometimes they do treatment of damage, during that scope procedure performed, while they're doing that scope procedure. So basically they will insert an endoscope into the joint through a small incision, as you can see here in the diagram. Okay. Now, since we are dealing with scopes, so you will probably going to hear us talk about scopes throughout the chapters, anywhere where it will involve scope. But as far as the arthroscopy goes, we're going to go over that guideline. Okay, so as far as the scopes, like I said, we're going to start off. I want to point out this code with you coders here, that 29880, and we're going to start from there and I'll show you the guidelines. Okay, so 29800 arthroscopy, you will find this as the diagnostic procedure, and you can see that separate procedure there. Now we reviewed this earlier, and so I'm going to bring in that guideline again. So this is the surgical guidelines. So remember that the separate procedure should not be reported in addition to the code for the total procedure or service for which or of which it is considered an integral component. So when we're talking about arthroscopy, we're going back here in our code series. It's telling us here in our guidelines too, in the chapter guidelines, that surgical endoscopy, arthroscopy, always includes diagnostic endoscopy or arthroscopy, meaning to say that in this code series, when you're dealing with scopes, that diagnostic procedure is going to be bundled into the surgical procedure. So to put it all together, so what you're gonna have to pay attention to when you're coding for diagnostic scopes, in this case arthroscopy, endoscopy, is that when a diagnostic scope occurs at the same time and in the same scope as the surgical scope or the surgical procedure or surgery scope, it is not going to be coded, it's going to be bundled. Okay, it's going to be bundled into whatever surgical code being done during that encounter. Now, if diagnostic scopes are coded separately, that's when you can only code diagnostic scopes separately for whenever that diagnostic scope is going to turn into an open procedure. Okay, so when an open procedure takes place within that same encounter of the diagnostic scope, that's when you can code for the diagnostic scope separately. All right, does that make sense, everybody? I think a good way to practice that is by doing a scenario. So if you're ready, I'm going to bring in a scenario here. So we have answer choices: A, 29881, 29874 with modifier 159, B, 29874, C, 29881, and D, 29880 and 29874 with modifier 159. Here's your scenario. An arthroscopic medial meniscectomy with removal of loose bodies, medial compartment is performed. What code or codes is reported for this procedure? And I'll give you a minute and a half. And your time starts now. Good luck, coders. All right, coders. Looks like you're doing great over there in the chat. If you haven't gotten your answers in, go ahead. I'll give you a few moments. And we really appreciate your participation there in the chat. Keep it going. All right. So let's go ahead. So for this scenario, the answer is going to be D. So great job for all of you who got it. If you missed it, let's go over this together so we can learn from it. Okay. So we're going to our keywords now. We have arthroscopic, medial, meniscectomy with removal of loose bodies, medial compartments. Okay, so I'm actually going to go ahead and dive into that 29870 with modifier 59 there, because if you look that up, the code description for this is arthroscopy knee diagnostic with or without synovial biopsy. So that with or without synovial biopsy, and this is also a separate procedure. So remember that rule, the guideline regarding this, the separate procedure, you only code it if it is not integral to another surgical procedure. In this case, we know that during the scope procedure encounter, there was another surgical procedure was done, that meniscectomy there. So this here is going to be wrong. So I'm going to go ahead and eliminate that. Okay, everybody, hopefully that makes sense. And so we're going to take a look at this family here. We'll start with 29871. Okay, so we're going to look at that up. That's another arthroscopy knee surgical. So this is that's the pairing code there. Going down to 29874, which again, this is still on the answer being, just to prove to you that this is going to also be wrong, because now there's two arthroscopic procedure, and this one is for the removal of loose body of foreign body, removal of loose body or foreign body. But then again, remember that 29870 must not be coded with another surgical procedure. It is going to be bundled because that 29870 is a surgical separate procedure. Okay, so we eliminated B. Now we're going to look up 29880 here under this family as well. That is arthroscopy knee surgical with meniscectomy. Now you have to pay attention here. We always tell our students to really pay attention to this, because this is meniscectomy, exactly what we're looking for, medial and lateral. So that and there makes this answer wrong, because if you look back, we were actually only dealing with medial compartment. So you only code 29880 if you're dealing with a meniscectomy for medial and lateral. Okay, so because of that, we're going to eliminate D. And now we're going to go down to 29881, another arthroscopy knee with meniscectomy. And this one here is telling us, as far as the location, is medial or lateral, meaning to say either of them. In our case, we know that we were coding for medial, okay, including the debridement and all this. But that's all we need, and we can determine that this is the code that we're looking for. So we like this so far. And look at that, the debridement for loose bodies, the removal of those are already in that code description as well. So that's all we need. So we can go ahead and eliminate A. And our answer is just going to be 29881. All right, how do you feel about that, coders? Hopefully it makes sense. Now, if you need more practice, then I have another one for you guys. So let's go over this together. So we have A, 29882, 29870. For B, 27446, 29870. For C, 29882. And for D, 29883. A 20-year-old college student suffered from knee pain resulting from an old MVA, arrives to the OR for the diagnostic arthroscopy and synovial biopsy to determine the source of the knee pain. The patient is prepped and draped in sterile fashion. After induction of anesthesia, small incisions are made in the knee area. The arthroscope is inserted through the lower incision. Saline solution aids in expanding the opening for better visualization. Through the upper incision, the physician takes a biopsy of synovial tissue. Upon further exploration of ligaments and structures of the knee, a torn meniscus was viewed in the lateral compartment. The physician sutures the meniscus tear, repairing it. Satisfied she has discovered and treated the source of the patient's pain, she irrigates the area, checks for bleeding, and closes the incisions. Which procedure code or codes best describes this encounter? And you know the drill, a minute and a half. So good luck, coders. All right, coders, get your answers in. I'll give you a few moments. And like I said, we really appreciate that your participation in the chat. So if you answered C, then you would be correct. So how did we arrive to this answer? So let's go over our keywords here. We have 20-year-old, we have diagnostic arthroscopy, and synovial biopsy. Okay, we have incisions, arthroscope, inserted, biopsy, synovial tissue, exploration. We have torn meniscus, lateral compartment, sutures meniscus tear, repairing it, and that's it. So if you look it up and then you look at your answer choices, you should drive your attention to that 27446. We call it as an oddball there because the rest of them are actually on a different family. So 27446, if you look that up, that is a code for arthroplasty, knee, condyle, and plateau, medial or lateral. Now look at that procedure there. That's coding for an arthroplasty. In our keywords, we know that we're coding for an arthroscopy. And so this is going to be the wrong procedure. Okay. The arthroplasty is basically repairing a joint. So with that being said, this is not going to be our code. So we're going to go ahead and eliminate B altogether. We don't even need to, pay attention to that. Okay, so now we can focus our attention to this family here. So we have a 29870. This is arthroscopy knee diagnostic with or without synovial biopsy. So we're in the right place. However, we're going to have to always remember this is a separate procedure. And remember the guideline as far as the scope goes. When a diagnostic scope occurs at the same time and in the same scope as a surgical scope, in our case, we did know that after the diagnostic procedure, the doctor actually had to repair that meniscus tear. So with that being said, we cannot code that diagnostic procedure is going to be bundled into the surgical procedure. So let's go ahead and eliminate that A there. because it's coding for the diagnostic procedure. Okay, so now we're left with C and D. So we're going to have to take a closer look at this. So both of them are in the same family. 29882 is for with meniscus repair. And remember that or and an or. So the 29882 is for medial or lateral. So we like this again because we're only dealing with a lateral compartment, whereas 29883 is same procedure there, meniscus repair. That is for medial and lateral again. And meaning to say you code this if it involves both medial and lateral compartments. And as far as our scenario goes, we're dealing with the lateral compartment. So that means our answer is C, 29882. So hopefully you got that correct, or if you learned something, that's we call it priceless here in AMCI. So hopefully you learned something and you get that priceless moment. And at this point, I'm gonna actually go back and join you over there in the chat, and I'm gonna pass the screen back over to.
Yes,
Is it
that would
gonna be
be.
you, Mrs. J?
Yes, indeed.
Wonderful.
Outstanding. I think they're doing an amazing job in the arthroscopy section. So great job, coders. And we're getting down to the wire, and it's my job to talk to you about excisions. All right, some of you may say, well, we've already talked about excisions in the in the integumentary section. No, I'm not talking about cutaneous or skin incisions or excisions. I'm talking about musculoskeletal excisions. And you're not to confuse these with the integumentary system. Now, one way you'll know the difference, these lesions or tumors are below the skin. So they are subcutaneous. They are in that fat section or below. It's going to be at the subcutaneous level or the muscle, the fascia, the bone, you know it. All right. So, and often these are tumors. And if you look at this picture, this does look like a tumor. It doesn't look like it's superficial. It looks like it's way down. All right, so we have some guidelines, and the guidelines actually tell you how to code or how not to code. You've got in this section here the excision of subcutaneous soft connective tissue. So, depending upon the level of the tumor, there are guidelines. And the most important thing that you need to know, do not confuse them with cutaneous. Don't confuse subcutaneous tissue tumors with cutaneous lesions. Also, the fascial or subfascial soft tumors, don't confuse them with subcutaneous soft tumors. You've got radical resection of soft connective tissue tumors. Now, these, whenever it's radical, often anytime it's radical, often it's cancerous. Don't confuse them with cancerous lesions. If you look down here below, 1160, no, let's just stay focused. We are below. Anytime you see that word tumor, that's your keyword. That's how you know that you're coding from the musculoskeletal system. Also, radical resection of bone tumors. Musculoskeletal system. And here are the guidelines, the general guidelines. When you're coding musculoskeletal or subcutaneous tumors, you code them from the musculoskeleton section, and remember, simple and intermediate closures are bundled in these procedures. So that's pretty much it. Knowing those keywords, not confusing it with integumentary system lesions, and intermediate as well as simple closures are bundled for the more for these tumors. Oh, by the way, I just want to tell you, Miss Rochelle, you did an amazing job. You did. Okay, so I have a scenario I would like to read to you. Are you ready, coders? All right, I know you got this. A 11404, B 27328, 12031 with a 51 modifier. C, 11404, 12031 with a 51 modifier. And D, 27328. A 19-year-old male college student bumped his right thigh while playing intramural rugby on the lawn of the Cathedral of Learning. He sustained a lump and a bruise, and the pain was so intense he had to be taken to the ED for treatment. The ED physician was uncertain but concerned about the lump on the patient's thigh, so he asked the dermatologist on call to diagnose the suspicious lump. The dermatologist diagnosed the patient with a 2.5 centimeter benign tumor of the right thigh and recommended that he follow up with his dermatologist for treatment. 2 weeks later, the patient arrives to the dermatologist for excision of the benign tumor. The patient was prepped, draped, and anesthetized appropriately. The physician makes an incision over the tumor through the skin, subcutaneous tissue, and muscle. The tumor was visualized, then removed. The site was flushed with saline. Hemostasis was achieved with electrocautery. The site was closed with sutures in layers. Which procedure codes best describe this encounter? Okay, coders, I'll give you 1.5 minutes. Go ahead, type your answers in the chat. Okay, I think I gave you 3 minutes. I apologize. All right, coders, how did you do? Did you say D? I hope you did, because that is the answer, and let's see why. Here are the key words: 19-year-old, diagnosed 2.5 centimeter benign tumor, right thigh, follow up 2 weeks later, excision, benign tumor, excision down to the muscle, tumor. removed, electrocautery, closed in layers with sutures. Okay, let's look at A. It's saying that 11404 is incorrect. And we know just by virtue of looking at the code, this is an integumentary code. And I just said that integumentary is not coding for below the skin, it's coding for skin and cutaneous lesions or tumors. But this tumor, we're coding for tumor, and tumors are generally coded in the musculoskeletal section. All right, so we have both 11404 at AMCI, and if you look at the code on the right-hand side, this is excision of benign lesion, including margins, excised diameter 3.1 to 4.0, which is incorrect, and it's the wrong size too. So we're going to eliminate A and C because we are coding for a muscle tumor. And why am I just saying muscle tumor? Because that is the deepest level that they've gone, and that has to be where the tumor is. You have to go through the skin and the subcutaneous tissue to reach the muscle. All right, I'm going to keep going. And 27328 is the correct code because this code is coding for the excision of the soft tissue tumor of the thigh or knee less than 5 centimeters. It's intramuscular. We know it's correct. And we know that B is incorrect because it's coding for the sutures. It's coding for intermediate closure. And remember, intermediate and simple closures are bundled. So we are going to eliminate B, and our answer is D. Okay, coders, I know you found that a little better, especially if you were paying attention to the guideline instruction, you nailed it. And if you got it correct, outstanding. But if you didn't and you learned something, that is priceless. Okay, so I am finished with my instruction for tonight or today or whenever you're listening to it, but it is daytime where we are. And I'm going to hand it over to Mrs. Tracy.
All right. Thank you, Mrs. J. And it looks like I will be, oh, sorry. Give me one sec. Sorry about that, everyone. Looks like I'm going to be finishing this up today. So we're going to talk about malunions and non-unions, okay? So we need to know the difference between the two of these. And just so you know, we code these a specific way. We're not going to use them from the fracture codes that you typically will see, and I'll show you that in a minute on the next page. But it's just really important to know the difference. So a non-union is actually when that fracture does not heal on its own at all, and that can be pretty serious actually. And there are several reasons for that. For the non-unions, could be due to not getting enough blood supply. Smokers actually sometimes will have fractures that don't heal properly or don't heal at all, and or sometimes infections. Okay, and then we have our non-union is when it fails to heal, and then the malunion is when it doesn't heal properly. So it's poorly healed or badly healed. Okay, and let's go ahead and look real quick. So just to let you know, we do not code these. There's a specific place where we will code these we code these malunions and non-unions under this section, a repair, revision, and or reconstruction. Okay, we don't code them from the fracture section. Alrighty, and I think, oh, I have a scenario for you, but I just wanted to show you this. Okay, so you'll be coding these malunions and non-unions again right under this subheading, repair, revision, and or reconstruction. And if you look down here at 24430, that's where they will begin, repair of non-union or malunion. So they both get coded from the same area, okay, whether it's non-union or malunion. All right, and I think that is all I wanted to tell you, and I do have a scenario for you. And here's our answers. We have A, 24430, B, 24515, C, 24500, or D, 24435. A 67-year-old male patient who sustained a fracture to the right humeral shaft a year ago presents to the OR for repair of a poorly healed humerus fracture. The patient is prepped and draped in sterile fashion. After induction of anesthesia, the surgeon makes an incision over the humeral shaft all the way down to the bone. He carefully retracts the nerves and blood vessels to prevent damage. Using an electric bone saw, the abnormal bony areas excise, creating a significant space in the humeral bone. Graft harvested from the patient's iliac crest is mixed with the patient's blood and is used to fill the gap and substantiate normal alignment. The surgical site is irrigated, then sutured. A long arm splint is placed for immobilization of the arm. Which procedure code best describe this encounter? So I'm going to go ahead and give you a minute and a half. Good luck. Last scenario of the day, and your time begins now. Okay, that is time. Get your answers in, please. And let's just quickly look at our answers here. So I noticed that all those codes are fairly close together. We have codes beginning with 244 and codes beginning with 245. So let's go ahead and reveal the answer, shall we? So did you say the answer is D? If you did, fantastic. If you didn't, that's okay. We're going to walk through this and I think you'll see your mistake. So let's go to our keywords. And just real quickly, just to let you know, again, malunion, that's poorly healed, and non-union just means it's not healed, okay? So 67-year-old is one of my keywords. We have fracture, right humeral shaft, year ago, repair, poorly healed humerus. So what are we dealing with here is a malunion, okay? Because it says poorly healed humerus fracture, incision, humeral shaft, down to the bone, humeral bone, graft harvested, iliac crest. All right, so that's all my keywords. And again, this is a poorly healed fracture, so that would be a malunion. Okay, so remember I showed you on the last page, right before we went to our scenario, where we would be coding these from. So we're going to be coding those from the not from the fracture section, but from the reconstruction section. Okay, so let's look. So if we look at 24500, this is for a closed treatment. So this is when we're coding for those acute fractures. So that is going to be incorrect, okay? Because we're looking for that keyword, malunion, okay? So we would get rid of that, 24500. So that's gone. And then we're going to also look at 24515. And again, that is also for treating for an acute fracture. Okay. And remember, these malunion codes and non-union codes do not get coded here. So we would get rid of answer B. Okay, now going up to 24430 and 24435, they're part of the same family, and that is the code we're looking for. That's the family we're looking for. Repair of non-union or malunion of the humerus. Okay, so I like that language so far. However, 24430 is coding for no graft, and 24435 is coding for a graft. Okay, so we just have to ask ourselves, was a graft applied here? Okay, so the answer is yes, because it says that a graft was harvested, okay, from the iliac crest. So if we look down, we can get rid of answer A, because that's coding for no graft at all, and 24435 is coding for a graft, okay? So if we look at the code language there, it says with iliac or other autograft includes obtaining the graft, okay? And that's the code we're looking for, so D is the correct answer. Okay. All righty. I think that's it. How did everybody do? Talk to us in the chat. Wow. I'm going to hand it on over to you, Miss Rochelle, but how amazing. I think this was a great class. I think they did a wonderful job today.
I 101% agree, Miss Tracy. I think we did. And coders, you did great. While I'm putting my screen on over here, looks like it's lagging a little bit, so I apologize. Tell us in the chat, how are you doing, coders? And see, it didn't go as I'm planning it. So I knew it. How are you doing, coders? We all hope that you learned something from our today's discussion, but don't go just yet because we have some more. We have some bonus for you. So this is a good resource for terminology and definitions. If you want to, you can pause the screen right now, and maybe if you're watching this on playback, you can get back to this and then maybe solve this for you. So on your left here are your procedures, and on your right is going to be, the definitions of those procedures. So I'm going to give you a moment to screenshot this, and like I said, if you're watching it on playback, you may pause, and then I'm going to go ahead and show you the answer on the next slide. So I'm going to do that now in 5, 4, 3, 2. Here you go. So if you want to go ahead and check your answers, I bet you did great on this one, because I think most of these we went through today. So great job, coders. And not only that, if you need more resources, we have some really great internet-based exercises for you. So go ahead and grab and screenshot them as well. And you may want to visit them for more information. And I think at this point, it's time to wrap it up, right, Mrs. J?
It is indeed. If you can, well, I think I can grab the screen. I
All right.
did.
Thank
Thank
you,
you
Mrs.
so
J.
much. Thank you, Ms. Rochelle. Thank you, Mrs. Tracy. You all did an amazing job. Now, it's my job to recap what you've learned and what we've instructed. We provided instruction on wound exploration, introductions and injections, fractures, instrumentation, spine procedures, foot procedures, hallux rigidus and valgus. Remember those, that is arthritis and bunions respectively. Casts, arthroscopic procedures, subcutaneous excisions, malunions, and non-unions. So you have done an amazing job in that chat, and hopefully you'll come back next week to talk or learn about respiratory system guidelines. And for those who are here to get the homework, you can find it right in above the comment section, right in there. You can get that homework. That homework will be there for 24 hours. And I just want to thank you all for doing an amazing job. I was chatting with some of you in that chat, and you guys are amazing. And I want to shout out the AMCI team: Miss Tiffany, Miss Angela, Miss Sarah, Miss Anna, Miss Jody, Miss Mia. Did I miss anybody? If I missed you, I'm sorry. I love you. All right. So, if you will, Miss Rochelle and Mrs. Tracy, please take yourselves off mute and come and say so long. And I just want to tell you that you are the best YT team in the whole wide world. Thank you so much.
Yeah, thank you, Mrs. J. This was a great presentation, and I really enjoyed my time over here today with you and with you too, coders. So we hope we'll see you back again next week because I think we have another great one coming up for respiratory system. So have a great weekend and so long, as Mrs. J said. Thank you.
Yeah.
And I just want to say you all did a great job. I want to thank you for coming in here and spending a little bit of your Wednesday with us. We appreciate it. I hope you learned a lot, and we will see you next time.
Yes, thank you. Thank you both. Oh, one last thing I want to tell you. If this instruction was too difficult for you, there is a course for new coders and it's free. So contact us at our customer service department. Just go to www.absolutecodinginstitute.com, click on contact, and our customer service team is very happy to help you. Or if you thought this was good, but you need more instruction, yeah, we have more. If you like, there is a course that we have. It's called the lecture series or the fast track course. And we do extensive discussions on these topics. Yes, more than we're doing now. Absolutely. So just click on our website and you can register or sign up for those courses. And also I think there is a coupon code for 10% off. They're very reasonable. So I would take advantage of it. And if you like this instruction and you want more, go for it. All right. Okay. So on that note, I'm going to say so long. We've been here a long time. All right. Take care now. See you next week.